COVID lives or something. Some sort of COVID video. I've been shooting something pretty much every day right now, so pardon me if I get lost in the techno language. Um, yeah, so I wanted to talk. I just wanted to continue the conversation around the narrative. Um, Try to reduce some of the panic and fear that seems to be plaguing everybody. Something really important to think about, to talk about. Again, I'm not a virologist, I'm not an epidemiologist. I'm just applying some logic to this from the standpoint of my life history, my perspective being a doctor, having been a military doctor, having been in the military, all of those types of things. I would like to see what I can do to kind of decrease the anxiety of the unknowns. All fear basically is coming from the unknown. It's the dark. If you shine the light on it, it becomes nowhere near as fearful. So with all of the information out there about how many people are dying and these young, healthy people are dying, these healthcare providers and nurses and otherwise healthy 30-year-olds and all this other stuff, there's a lot of people who are actually afraid of dying from this disease right now. A lot of people now there's a significant portion of the population that may have to fear that, that has a reasonable reason to fear that. But I think the vast majority of people are overestimating how deadly this disease is for people who aren't over 65 or 70, and for people who don't have serious or significant existing health conditions already. So the first thing I would like to talk about, I'm going to share my screen here. Let me see, I'll just share the whole thing. So to recap, we basically have almost 1.5 million coronavirus cases. This is not actually, nomenclature of that is off, I believe. We don't actually have that many cases. The media has been clear and the CDC has been clear that we actually want to consider COVID. COVID is actually being, COVID-19 is actually being the virus, and the nCoV SARS-2 is actually being, that's the virus and the COVID is the disease. So coronavirus cases, I'm not sure exactly what it means, other than it means that those are positive tests. Now, that doesn't mean we have 1.5 million current cases. That means that we have that many positive tests total around the world. And as a little scale on that, America's tested over 2 million people. So the entire rest of the world combined with America is 1.5 million. Of those, only about 1 million of those are active, because if we look up here, 320,000 people have already recovered from this, and this is worldwide. This number here is always 90, between 94 and 96. So it's averaging around 95, meaning that 5% are critical or serious cases. These are cases of people that might die. And let's be honest, what we're worried about is death. If all this was just saying that you're going to get a flu-like illness that's going to make you cough and give you a sore throat and give you a fever, none of this would be happening. We wouldn't be having this discussion. We're worried about deaths. How deadly is this? Okay, well, if we're saying only about 5% of these cases are serious or critical, that 5% moves over here to cases we're going to track. Of course, we're tracking some of these, but we're definitely tracking the serious and critical, because these need medical attention. These are being hospitalized. These are being admitted to ICUs. These are the ones being intubated. And this number here varies. That 22 is the highest I've seen it. It's been about 20 the entire time. This will vacillate between 19 and 21. So it's averaging around 20, depending on what time of the day. So that means one out of 5 are actually dying out of this group. And this is the important thing to remember, because what we really don't know is almost everything. There's only a few things that we know reasonably well. We don't have any idea how many people died in China. There's way too many conflicting reports around there. What we do have pretty good data on is like the last 6 to 8 weeks between the European countries. Well, lots of countries. The European kind of being the hardest hit, other than America. And so we have a pretty good track on the number of deaths. And so if we look down here, we have, Charles, can I move this thing? It's always right in the middle of my screen.
Yeah.
I click on, oh, look at that. Sorry, folks. I'm a doctor, not an IT guy. Okay, so here's yesterday. This is Worldometer, however you want to say it, Worldometer. We threw up a big number yesterday, almost 2,000 cases. We were right around 1,000 for about 4 days, I think, 5 days. Went up to a high of 1,300, and then bam, all of a sudden we're almost 2,000. And then today we're already at 1,400, and we're, another 6-7 hours from this being over. So we're probably looking at 2,000 again, which seems like a really big number. And it, definitely could be concerning, but and what I'd like to draw your attention to, and if you haven't been to this chart, I recommend going to this. I recommend you going and doing research and looking up everything I'm talking about. I'm not always right. I reserve the right to be wrong about anything I'm saying. I'm simply giving you my basal understanding and the narrative I'm running in case that could be helpful. So you can organize these by clicking, total cases. It'll tell you where the most number of cases. America, currently, we have 418,000 positive tests. That's 18,000 more than we had yesterday. Our total deaths are 14,000, which is already higher than I predicted at the beginning. I thought this was going to be around 10,000. I said a high end of 30,000. Hopefully I'm right there. Not because I'm a genius. I was basing it off of other people's data, though, and maybe that's right, maybe it's wrong. You can look at total new deaths. America, again, the top of that. The UK being the next. Spain, Italy, France, the usual players. These are the hardest hit countries. Italy was running around 1,000 for many days. Spain was running around 1,000 for many days. The UK was down around 400 or 500. That seemed to be shifting places. And what's interesting, what we'll talk about in a second, is that there seems to be a familiar pattern to this, and there's every reason to believe that this is going to go up and go down. A virus cannot kill all of its hosts and still be transmitted. It has to be able to be caught, and the host has to be able to survive long enough to pass it on to another host, or the virus won't keep going. So that's one reason that you won't see this, kill everybody, obviously, because it's not doing that yet. And if people died too rapidly, it wouldn't have time to transmit. That's one thing. There's another possibility that there's seasonality to it, meaning that weather could impact how virulent it is, and even possibly how deadly it is. But these are things we don't know, but I'm going to compare it to some data we've seen in the past. And then the other part, when they're doing these models and they're talking about based on what we've seen, and what models do is they project the future based on the past. So based on what we've seen, we think this might happen. And if you'll remember, a couple of weeks ago, they were saying 2 million deaths in the US. And then that went down to 100 to 200,000. And now they've revised that, I think yesterday or the day before, down to 80,000. There's talk now that that's going to be revised further in the next day or two. We might get down to 50,000. Hopefully we get down to 30,000 or so. And then that kind of makes this not too abnormal of a flu season. Because at that point, what we're talking about is when you have these models, not everybody, part of predicting that curve is you have to predict who all is susceptible. So who's going to be exposed to it is one issue. Just because you're going to be exposed to it, does that mean that you're going to be symptomatic? Does that mean you're going to give it to other people? If you live in the middle of Wyoming, versus you live in New York City, how many people do you interact with? What are your odds of infecting other people? So this ends up being an average over an enormous country that's not at all alike. Like living in Cheyenne is nothing like living in New York City. But susceptibility matters. So how many people can I possibly spread it to out of everybody on the planet? How many people am I going to interact with? And how many people are they going to interact with? That would be one issue. But will the person who catches it, gets exposed to it, will they actually become infected? That's one case. Do they develop symptoms? That's two. Do they develop severe symptoms? That's three. And do they die? That's four. And right now, all we can really base this on is death. And again, like I said, the only reason we're having this conversation is because we're worried about killing a large portion of our population. And so it's very likely that the susceptible people are dying off early, and there won't be enough susceptible people later on to carry that model on, because there won't be enough people who are susceptible enough to this that they're going to die. And if we're tracking deaths, there's every reason to believe that the death toll will spike, and then it will flatten, and then it will start to decline. And we may then infect another metropolitan area and kind of see the same ebbs and flows. Hopefully we develop some more effective treatments toward this. Possibly we get a vaccine sooner than a year. Don't know. I don't have the answers to all of this. This is all speculation. But let's keep going with this. Chart over here, total recovered, you can organize by that. Active cases, you could organize by that. America has the highest number of active cases. Now, to me, this is the more important number. If we go by serious and critical cases, America is by far the highest. And if we remember up here, the only people who might die are people in serious and critical cases. So if we're tracking deaths, what we want to know is how many serious and critical cases are there? And then how many people are dying out of the serious and critical cases? Well, it turns out to be, pretty steady. What percentage of people from this are dying, right? We've already talked about 1 in 5. We almost have 10,000. We're getting close to 20. We almost have 10,000, and we're getting close to, say, 400,000. That would be about 25%. But let's say serious and critical, 1 out of 5 of those might die. So this is important. 18,000 new cases today so far. If we look at yesterday, we added 33,000 new cases yesterday, and we hardly had any increase in the serious and critical. Now, this has only gone up about 100 today from, so this was Tuesday. Monday, we went, when we had about 1,300 deaths, we went up from 8,900 serious cases to 9,100. So we only went up 200 cases, even though we added 200 serious and critical cases, even though we added 33,000 new cases. And then there's something to be talked about with that. I don't know, maybe we'll get into that with the questions. But the next question is, what are we considering a positive case? And the other thing is, what are we considering a corona death? There are rumors. There's not just rumors, but it's being published in various media outlets. I haven't seen any official guidance by CDC or NIH, or NIH wouldn't do it, but by CDC or other government bodies that are saying what constitutes a corona death. In other words, if you go to the hospital and you're dying and you go into the ER and you end up being admitted and going to the ICU, well, let's say if you're elderly, say you're in your 70s or 80s and you come into the hospital with pneumonia, if you go to an ICU, you're going to get an infection. And that's just the way it goes. And currently you would get a corona infection, obviously. So doesn't mean that you necessarily die from that. It might not have anything to do with your symptoms. You might die anyway. And is that person considered a corona death? But we're not going to split hairs on that just yet. But just keep that in mind, that all of this has a narrative to it. And there's a difference between who we test and how we classify things. So every healthcare professional doesn't necessarily have the same threshold for every patient. If you come in and you're 25 years old and you're exhibiting symptoms and you're completely robust and healthy, but you're really annoyed by this cough and you really feel like you can't breathe that well, but your saturation is great, they may just say, hey, go home, right? You're not a serious and critical case. Whereas if you were 50 and the exact same thing existed, maybe they'll bring you in. If you're 70 and the exact same thing, of course they're going to bring you in. Okay, so serious and critical, how much is that changing? That is not changing very rapidly. That is the best news. If we're only seeing a couple of hundred of those increase, let's say 500 increase per day, and let's say the average person is lasting 6 or 7 days in the hospital, in the ICU, under a serious or critical case before they die. Well, if we're only adding 500 serious cases a day, we're probably only going to lose about 100 people per day out of that serious and critical. So it took us every bit of a month to get up to around 8,000 critical cases. We've been, drastically increasing the number of testing, the number of cases that we have, and we're only up to 91, 9,200 right now. So that is positive news, something to think about. Now, the other thing I want to talk about quickly before we get to questions, let's look at this one. I guess you can see all of my screen, right? Can you see all of this, Charles? Okay. So if you look at this, this is also the CDC here. CDC National Regional is called Flu View Interactive. And what you can do with Flu View is you can, we can choose like what do we want to compare on here. We can look at different regions. We can go by state. We can look at different kind of labs. And we can look at years, and this is the more important thing. So if you notice, this does not start with January 1. This chart down here, this is starting with week 40 of 2019. And of course, it's going to go all the way out to week 39 or 40, 39 of 2020. And that is the flu season, because that's when things tend to spike. So the reason for optimism, I believe, anyone who remembers the H1N1 swine flu, that was very similar to the 1918 Spanish flu, which was also a swine flu. Well, let's look at a normal year first. So if we go back to say 2007, 2008, again, starts with week 40, spikes up, this, goes up. These over here are number of positive specimens, so number of positive tests, essentially, up to 5,000 per week. It goes back down somewhere around, April, May, goes down to essentially being a non-existent number, and that's a normal flu season. And then all these different colors down here are saying, well, what type of flu are there? And if you see already down here, this is 2007-8, swine flu already existed. Here's H1N1 down here in orange. But if you look, there's almost no orange in there. This number here is the number of visits for what's called influenza-like illness, which includes flus, but any type of pneumonia, essentially, especially when it's considered to be infectious. And there's a peak that corresponds with this peak, the number of visits people go in to see healthcare providers because they feel like they have the flu. And then, of course, this crashes with the curve crashing. So if we go to 2008 and 9, here is our flu season. And if you look at this peak, this is 4,000. So it's a little lower than the year before, but that would be a normal variation. There's normally between 30,000, high 20s, and high 50s. So between 30,000 and 60,000 people die every year just in America from the flu. But it all occurs in these weeks right here. Now, if you look at this H1N1, this did not have the same seasonality as the regular flu. So we have this second spike. Again, the H1N1 is orange. This is swine flu. And look at how much orange there is. And we have this entire second peak that's all orange. And there's a little bit of the regular flu in here, but this is almost all H1N1. And then you see this starts declining again. And then if we go to 2009, 2010, here I think is the most hopeful part. We actually have 2 spikes of this H1N1 taking us all the way through the end of the year. This is spiked up to 13, 12,500, people coming in, or numbers of positive tests in a single week. So that's huge, right? That's almost 3 times what we saw in the other peaks. And then it goes down to essentially nothing. Now, here's the interesting thing. We just said that the normal flu season kind of starts around here and peaks somewhere around here and then drops off somewhere around here. We essentially don't end up having a real flu season apart from this H1N1, which happened earlier in the year. And if we go back to the year prior, it basically came right after our regular flu season. We had this big spike. It started going back down. It went back down to a really kind of insignificant number down here. And then it started coming back up, and then it went back down. And then we had no more infections here, because when we're talking about susceptibility, these people under the peak, under that peak, that area under that curve, and these 2 areas under these curves, these are the susceptible people. So if we don't have any more people who are susceptible to getting ill enough to go see a doctor, or susceptible enough to becoming ill enough to be a serious or critical case, or susceptible enough to die from this, then we run out of susceptible people and the virus peters out. And hopefully by that time we've developed some better treatments. That's my poke at hope right there. I don't think that there is, I don't think that this is, the virus itself is completely novel. I do not think that the situation is as novel as we are worried about it being. Of course, it has the economic impact that swine flu and other epidemics didn't seem to have as much of, although the Spanish flu probably had close as much of, because it killed so many people. But when we look at the number of people who go to the hospital and the number of people who are becoming serious and critical, that number is really fixed. And it's fixed, the deaths are really fixed by the susceptible. There are the outlying cases. There is the healthy individual that's fairly young and is dying from this for no apparent reason. So I'm not saying it's not serious. I'm not saying it's not important. I'm not saying be flippant. I'm not saying disregard the rules. Of course, follow the rules in society that are going to help us all get through this, but also follow the good health habits and guidelines that are going to help you get through this and help you be as healthy as possible, and your family members and those that you care about and love. Let's make all of those people as healthy as possible so that we can get back to this as quickly as possible. The better everyone's immune system is, the fewer people are susceptible. Sleeping well, eating well, being active, and maintaining control over your stress, decreasing your stress, and optimizing your mindset throughout the day. These are all things that are going to increase your immunity and make you less likely to have symptoms, make you less likely to get severely sick, and make you less likely to give it to somebody else. That's where I'm going to stop with that. And I'm going to answer some questions now. We're about halfway through this. What do you got for me, Charles?
So Mike S.
Okay.
Do you feel that if the Southern Hemisphere sees a large breakout of cases during the summer, that is predictive of this coming back in the fall for us in the Northern Hemisphere?
Well, I've not studied, I've not studied that epidemiology to the point where I could say predictively what I think. What I've been reading and what I've heard from experts is that there's no guarantee that this is actually seasonal, meaning that we don't know for sure that it's going to have anything to do with the summer. Like if you look at this H1N1 graph, I'm sorry, this was Mike S. I didn't announce your name, Mike S. If you look at this H1N1 graph, this didn't really have the seasonality that we would expect with the flu. It, interestingly enough, I want to share one more thing. That's the one thing I forgot to share. Interestingly enough, if we go after 2009 and 10 and we go to say 2010, 11, and we look at the composite of the peak, again, it goes back to normal. It goes up to fairly normal. We're peaking around the same numbers. We're having around the same number of deaths. But look at all this orange that didn't even exist a few years ago, right? We didn't have any orange. And now every couple of years we go up, which viruses are making up these influenza-like illnesses changes. So this is almost all influenza A. This is 16, 17. And we had this really bad flu season in 17, 18, and we had a lot of that. And then if we get to 2018, 19, look at all that orange, a ton of H1N1. Again, that wasn't even a player before. And then we get up into this season, and then a ton of oranges again. So we have a lot, there's a good chance that this is going to essentially get wrapped into our normal influenza-like season if it shares the seasonality. Like H1N1 didn't share seasonality before because the susceptibility, I believe, is the cause. If you didn't have if you don't have susceptible people, then the H1N1 dies out and then becomes an issue again when people become more susceptible, meaning that the daylight's gone out, activity's gone down, people are hunkering around their houses and locking themselves up in cold weather and being around each other and exchanging more viruses and bacteria and stuff between them. So if there is a seasonality to this, then maybe the Southern Hemisphere could be predictive. But, if you look at sort of equatorial regions, if you look at, the South, if you sort of look at Southeast Asia, they don't have seasonality with influenza. It's contagious all year round, which is one of the reasons they're better able to deal with this than we are. They have more precautions in place because that's a more common thing to infect and kill people because it does it year round. So they're kind of on their toes around this all the time. So that's why they're better. They have all these temperature checking things. They have all these positive pressure rooms. They have all this, safety equipment around it. They're really good at isolating and quarantining. So I can't say for sure. My guess, again, is that this is going to wrap into one of these curves like any other influenza-like illness. It's going to be part of the picture from here on out. And it's probably going to affect the same susceptible population, the same percentage of the population every year. And it's very likely to just become part of our flu season. Well, maybe next year, maybe it takes 2 years to get there, but that's just looking at what's happened historically. That's the most likely thing, because if you look at those charts, if you go to the CDC and look at those charts, there's a lot of things that are in that. It's not just one or two viruses. There's all sorts of viruses in there. And influenza-like illness can even, that can even include bacterial infections because it just looks like influenza symptomatically. What else?
Steve F.
Steve F.
Can you discuss a bit about herd immunity?
Herd immunity. So that's sort of what I was just talking about with susceptibility. So if you think about herd immunity, it's super easy to do this if you think about herds. So think of like water buffalo, or antelope or gazelle, something that lions hunt. I'm not good with those nature shows. I don't really know, but something that lions hunt. And instead of it being a virus, the thing that is threatening the herd is this lion or groups of lions, whatever. Now, we know logically that the very young and the very old and the sort of broken down are more likely to be caught by the lion. And when we look at H1N1, that killed a lot of children. It killed a lot of the very young and it killed a lot of the very old. The most important independent variable for your risk of death from any cause is age. The older you are, the higher risk you are for dying of any cause. And it gets way, way higher. When you're 80, your risk of death per 100,000 is like, I don't know, it's like 1,200 per 100,000. Whereas when you're 50, it's like 300 or something like that. So it's a really big difference the older you get. So if we say, okay, well these lions can only catch, they don't mess with little ones. They're only messing with the big ones that are old and slow. So that's going to be a certain population. Now, at some point, that population is going to be fast enough and strong enough and agile enough. And maybe it's a sense of smell. Maybe they can smell the lions, and so they react faster, and it's not necessarily speed and agility. But at some point, the lions sort of pick off everyone that's susceptible, and then the rest of the herd becomes really hard to kill and catch. Now, the same thing is herd immunity with a virus or a bacteria. So this is a completely novel virus. Our immune system, nobody's immune system on this planet, other than somebody who's had it in the last 6 or 9 months or however long it's been around, before a year ago, presumably, there was no one's immune system on this entire planet, no animal on this, well, I can't say that, no human's immune system had seen this before. And so that means that it's going to, when we contract it, when we get infected with it, whether we put it in ourselves, whether we breathe it in and we touch our eye, we touch our nose, or however we do it, swap bodily fluids, kiss somebody who has it, like however we get it, but you get it, it goes into your body. It will infect a certain number of your cells, and viruses are not alive. They're not active in any way. They essentially attach themselves to cells. They get pulled into the cell. The genetic material inside of that mixes with your genetic material, and it turns your cell into a factory that makes viruses. And once it makes enough viruses, that cell literally ruptures and dies, and it spills a bunch of viruses into the bloodstream, and then they attach to other cells, and this goes on and on until your immune system figures out the game and says, oh, we know what this is. We're going to put antibodies on there, right? And the antibodies are like a marker, so it's like putting a strobe light. You're tagging every villain with a strobe light, and now all the good guys can go out there and attack all of the strobe lights because they're really easy to find and see. And that's when you develop immunity to it, when you get so good at strobe lights that this virus has no chance of infecting more than a very small number of cells, and then you're going to get past it. So once everybody has antibodies, once everybody's been exposed, that doesn't mean that nobody's ever going to get the virus again. What it means is that people who are overall healthy, who have healthy immune systems, and they get exposed to this virus, are very unlikely to develop an infection of any substantial portion that's going to lead to any serious health consequences. Of course, if you are immunocompromised, and that can happen for lots of reasons, and if you are older, if you're elderly people have weaker immune systems. So we will still have people dying from coronavirus, even if they've been exposed to this. Like, a lot of us have been exposed to certain variants of influenza B, like the normal flu viruses. And if that comes back around, if that same variant comes back around, we don't really get sick from it. We may get a ton of it. We may breathe a lot of it in. We may, put it in our eyes and mouth all day, and we don't really get sick from it. But if our immune system wasn't all that great, if we are immunocompromised, we could still die from that, even though we have some level of immunity to it. So the idea around herd immunity is that once everybody develops antibodies, then you're not going to get sick. And if you don't get sick, then you can't spread it to somebody else. So you're no longer somebody who's susceptible to getting it, and you're also not somebody who's contagious. And so we greatly reduce the number of people who are getting sick and dying from this. But to some extent, that will continue to happen as long as this virus is around, which, the flu has been around hundreds of years. So there's a good chance this gets added in. Swine flu, H1N1 gets added in hundreds of years. And coronavirus gets added in hundreds of years. But overall, society will be better able to handle it. And then if we can come up with vaccines that will reduce that, and you can debate the vaccines all you want to. I'm not weighing in on that. I'm just saying that that's one of the things we use to mitigate, and then more effective treatments. There are some treatments that look very promising right now, and that's why there's a lot more reason for optimism than just those very, very slowly growing serious and critical cases. Next question.
Jocelyn O. Her questions are about autoimmunity. From what you've seen, do you feel that those with autoimmunity are considered higher risk for the critically ill category? And when they talk about a cytokine storm that comes with the virus, what will trigger an even stronger response in those with autoimmunity?
Okay, so Jocelyn O asked a question about how coronavirus is related to autoimmunity. So let's be clear is that autoimmunity is basically a impractical or non-helpful inflammation and attack of your immune system attacking yourself, right? That's what the auto means. So you're actually, your immune system is attacking some cells of your body. Now, exactly why they're attacking these cells can vary greatly. The most common thing, though, is that we're developing, we've developed some sort of antibody that looks very similar to this type of cell in our body that has very similar protein markers. And so that antibody is being attached to maybe skin cells. And so our immune system is attacking those skin cells as if they're the virus or bacteria that got tagged with this antibody, or virus that got tagged with this antibody. And our immune system is designed, has a memory to it to attack this virus. Well, maybe we don't have this virus, but the protein structures on our skin cells, or certain regions of our skin cells, because of UV damage or something. I don't know exactly. Nobody knows exactly why it happens in those certain spots. But your immune system is attacking those cells. So does that make you more susceptible to coronavirus? Now, that would be a question you could easily look up. You could go to NIH, go to PubMed, you could go to probably CDC even, and you could look up, what is the correlation there. However, we don't know very much about coronavirus, period. You could look that up in general for, are you more susceptible to viral infections if you have autoimmune disorders? Now, intuitively, what I would say is that not necessarily. If you have a very robust and healthy immune system, and it just happens to be attacking some aberrant cells, or some cells that look like some other infection that you've developed antibodies to, or you have this leaky gut and things are leaking into your gut that are developing antibodies that you shouldn't even have antibodies to, and those are attaching to other things, and that's leading to autoimmunity. But you could have a very robust immune system and be fairly young and healthy and just have not a hugely different. Of course, any resources you're wasting on fighting something that shouldn't be fought, those are resources you could have used on the viral infection. But that doesn't mean that you won't be able to prevent yourself from becoming serious or critical. You may have slightly more symptoms, but these are all reasons to focus on the lifestyle of sleep, nutrition, exercise, and stress mitigation. That's the 99% solution for the immune system. The supplements and so forth are supplemental by definition, and those are the 1% solution. So the short answer is, I don't know. You could look up what the data is currently suggesting, but we don't really understand pandemics. We don't really understand viral infections until about 2 or 3 years after they've happened, and we've had enough time to go back and look at the data and study them in labs. So I don't think anyone knows, but I think if you're otherwise healthy and maybe have psoriasis or something, I don't think that's a significant risk variable. If you look at how many people are, getting severely ill and dying from this, that's not listed anywhere along the comorbidities that I've seen. It's major things like cardiac disease, pulmonary disease, neurological disease, sepsis, the standard killers. What else we got?
Okay, there's no name here for this one, but the question is, antibiotics only work on bacteria and not viruses. Is that correct?
So antibiotics only work on viruses and not bacteria. Is that correct? So antibiotics are antibacterial. So those are designed for that. However, you have to remember that all of the drugs are man-made, and the drugs are man-made. By and large, where most drugs come from is we find a plant or something that exists in nature already that seems to be helpful. And, we look back through old wives' tales and folklores and medicine men, and we find, the palm of this, the heart of this palm plant actually does have some anti-malarial properties. And those anti-malarial properties protect people in that region who've eaten this. And so we study it and we say, well, it's this molecule and this is the molecule that's helpful. And so we mass produce that molecule and give it to people in pills. And so that everybody doesn't have to eat plant hearts. Antibacterials, they're not, it's not that there's some substance in the world that we say, oh, well, this is like this chemical is designed to kill bacteria. No, this chemical has properties that can affect the life cycle of a bacteria. So that could change like an ion channel. That could change the exchange of the polarity of the inside of the cell and the outside of the cell that makes bacteria more likely to have poor function. It could be things that prevent the cell walls of bacteria from forming well. It could be things that causes leaks in cells. It could be things that make your immune system more able to attack something. So the mechanism of the pills is not the same as the category or family. So a family of antibiotics don't all have the same mechanism. There's a ton of different mechanisms. That's the different classes of antibiotics. And it turns out that sometimes those can be helpful. So as an example, why is a malaria drug, there's chloroquine and hydrochloroquine, why are these helping with this viral infection? When malaria, and we know this viral infection is affecting our lungs, right? And malaria is actually affecting our red blood cells. And it's like this parasite that lives in our red blood cells and causes all these problems. So why is this drug helping? Well, it turns out that that drug binds certain regions of the red blood cells that are being attacked by this virus. And this virus is killing people's red blood cells' ability to carry oxygen well. And so now this drug that's meant to kill this parasite in red blood cells is protecting red blood cells for a different reason. And now it's actually becoming antiviral. Now, all of the other antivirals, and we have a ton of antivirals out now, right, which all started springing up in large order after HIV crisis came out. And so we have all these antiretrovirals, and they are affecting the life cycles of viruses. So again, the mechanism of a drug is how we classify a drug. That puts it in certain categories. That doesn't mean that it necessarily won't affect other pathways. So the short answer is like antibiotics, especially azithromycin, is proven to be helpful with viral infections. So it's not necessarily true, but that's the rule. That's the general rule. There are exceptions to the rule, but the general rules is, yes, they work in the categories we've put them in, but they tend to have some crossover as well.
Another one without a name. Is the only way to terminate the SARS-CoV-2 by destroying the virus's lipid fat coating via strong soap and hot water?
So is the only way to terminate the virus by destroying the lipid layer that's protecting the genetic material inside the virus, and soap and water versus
just those two methods. Are those the only two?
What's the other two? So soap and water and
hand sanitizer.
Oh, hand sanitizer. Okay. So yes, if you have this protein shell and it has these little spicules off of it, you've seen those, and these are things that recognize and bind. But we're just going to make this ball, and then inside of this ball, in the middle of this ball, there's some genetic material, and lining this ball is a layer of fatty-like material, right? And that's basically keeping out fluids, right? Because we know oil and water don't mix, and so fat is essentially an oil. So we have this layer in there that's keeping the positive charges, the liquids, out of the viruses, and it's maintaining its integrity. Once you get rid of that lipid layer, you can destroy the material inside, and it also degrades the shell itself because of structural reasons. So soapy water does what we call micellization. So it forms a bunch of regions that can stick to fat molecules, and then it's polar on the outside, so they can stick to water. So then you basically you have something that'll stick to a droplet of fat, and then the water can wash it away. And then you keep doing that until it completely goes away. And once you get rid of all the fat, you produce a big enough hole, and fluids and air and like whatever, like things can get in there that shouldn't be in there, and the thing degrades. So that's how soapy water works, which is why you need to do it for a sustained period of time. If you've ever washed greasy dishes, you've seen it break into little circles, little globules. And the longer the soap's there, the smaller those bubbles get, because the more and more of it you're breaking up. Hand sanitizer is an alcohol, and alcohol has similar properties to both fat and water. So you can actually dissolve things. You can dissolve fatty things in alcohol bases. So to answer your question, hand sanitizer and soapy waters are the only things that we know for sure that will degrade the lipid layer to allow the virus to be inactivated by degradation. But there's a very good chance that radiation does it as well. If it has seasonality, that's one of the things about UV rays, is that can actually cause it to degrade faster. But time is another factor. So if you just put one virus on a desk and you don't touch it for a week, it's gone. It's still going to degrade. So what we're doing is trying to degrade things faster. So there's some evidence that heat helps break down coronavirus. Like I said, there's a good chance that sunlight, UV radiation is going to break it down. Both of those things would then suggest that there's going to be some seasonality to it if both of those things are true. And then, yes, the other two things would be soapy water and alcohol bases. Don't wash your hands in beer, though. That won't work.
Lucy S.
Lucy S.
Wondering what you think about running in suburban areas. Her concern is basically about airborne particles passing too close to other people with social distancing.
Yeah, so I think, what was her name again? Susie S?
Lucy S.
Lucy S. Should you worry about running in suburban areas? Yes. To some extent. So if you think about this virus, these things are infinitesimally small. And what does it mean for it to be airborne? I did another video on that. But if something is airborne, it basically means that it can float around in the air for a little bit. It doesn't mean it floats around indefinitely. It's not an air molecule. It doesn't just float around forever. It eventually settles down. So think of like a dust particle. When you go into a room with the light shining the right way through the window, you can see all those dust particles, and they're just kind of floating as sort of glimmering, and they eventually go down to the ground. The lighter they are, the smaller and lighter they are, the bigger they are and the heavier they are, the faster they settle out. The smaller and lighter they are, the more likely they are to be whisked around by air currents. So when we talk about it being airborne, and it almost certainly is, influenza is also airborne. To what degree is it airborne? To what degree is it contagious? So if I'm breathing, and let's say I'm breathing out virus particles and they're not in water droplets, right? That's the sneezing and coughing thing, but they're not in any sort of water droplets. They're just in my breath, and the viruses are coming out when I breathe. What's the concentration of that? Is it 1 part per million, 1 part per billion? Is it 1,000 parts per million? Like, we don't know the answer to this, and it would vary from person to person depending on your viral load. However, if you think about this like dust particles, and you say that of all of the dust particles in the entire world and in the air, which is all around us all the time, where there's always these dust particles, there's always these little things floating around in the air, what percentage of those are coronavirus? Astronomically small percentage of those. So if you're running and there are people in your urban area that are breathing this out, but you're running outdoors and you have a lot of wind coming by, and you have different chemicals in the environment, you have heat coming off the road, you have vehicles driving by, like there's all sorts of things that are interrupting that flow. So how much is it being stirred around? and how quickly is it settling. Um, I did another video where I talked about the susceptibility, basically, of something called the viral load. So there's a really good chance that everybody on this entire planet is going to be exposed to coronavirus in the reasonably short term. That could be 2 months or 2 years. I don't know exactly what that means, but if this virus sticks around, there's a reasonably good chance that everybody's going to be exposed to it. So everybody needs to develop immunity to it. And the best thing to do would be to get the smallest amount possible, just to show your immune system what it is and develop an immune response to it, not even have enough in you to get really sick. You just go, oh, my symptoms were super mild, or maybe I didn't even have any symptoms and I developed immunity to this. So the reason I say yes and no is because the no answer is, the no part of don't worry about it means that um, if you're robust and healthy and fairly young, and you aren't too well, you shouldn't be too worried about getting exposed to the virus, to the extent that you're not going out and taking care of your health in other ways. So are you more likely to be exposed to it? Yes. Is that necessarily a bad thing? Maybe. Depends on lots of variables. But I would still think, and we won't know this until we look back over the course of years, I would still think that airborne transmission is probably, excuse me, is probably not nearly as high as touching things and touching your eyes, and the other ways that we get this, sneezing and coughing, all of that. That was kind of proven by the cruise ships. The cruise ship, I think, had 3,500 people on it, only 700 infected people. And if you think about it, they were all exchanging air for a really long time. So if the airborne was a huge component of that, you'd expect almost everybody to get it. That's it?
Yep.
All right. And that was perfect. 55 minutes. That gives you guys an extra 5 minutes to your day to do something else useful. So I hope that this was helpful. Again, this is all about narrative. I'm not saying that this is not serious. What I am saying is that even with the worst numbers ever, so let me do this one more time. When we, come on, baby, work for me. When we go to here and we look at all of these cases, and we look at worldwide, we've had 1.5 million positive tests, and we've had 87,000, let's call it 90,000 deaths. And we go to the population, go to world population. Since we're looking at world numbers, why are you doing that to me? Deaths this year, 15.8 million people. Again, we've had 80 some odd, we haven't even, what did we say? 88 to 90,000. So basically we've had, we've had somewhere around here, 84,000. We've had 1.8, almost 1.9 million deaths. If you do the math on that, that turns out to be about 0.5%, meaning that if you've died in the last, if you've died this year, if you've died since January, if somebody's died since January 1st, there is there's roughly a 99.5% chance that they've died from something else other than coronavirus. Doesn't mean that coronavirus isn't significant. Those numbers are ticking up. It is becoming a bigger risk factor overall, but it's only 0.5% of a chance. So if it goes up 10 times, it's only 5%, which would still mean that 95% of people are going to die from something else. Again, not dismissing it, we should try to prevent every death that we can within reason. Going back to my automobile metaphor, people die in cars and traffic accidents every day. We know this. We aren't flippant about it. We have lots of rules around it. We have lots of safety standards. We try our best to prevent those. But if we are absolutely committed to not having anyone die from automobiles, we would have to stop having automobiles. And we aren't willing to do that. So again, I'm not suggesting anything about what we should or shouldn't be doing policy-wise. I'm just illustrating what we currently do is we accept some risk of death in lots of areas of our lives. And this is just one of those things that we're going to have to accept some risk for, and we're going to do what we can. We're going to social distance. We're going to wash our hands. We're not going to sneeze and cough on people. We're going to wear masks if we're around people in high risk, or wear masks in the short to near term until something big has happened treatment-wise. I don't know exactly what the policies will be, but you can take all of those precautions and still recognize that your risk of getting in your car and getting killed in a traffic accident is much higher than dying from coronavirus. And so we just add it to the, the factors of life that are risk. All life is fatal. Everybody dies. Nobody gets out of this alive. Everybody dies. And we're all going to die from one cause or another. And we are doing our best to mitigate our risk, to control to the best extent we can when we die. Hopefully we're dying as late as possible. If we just focus on the fact that this is now something that we're adding into it, and hopefully, like I said, it will just add into the susceptibility of the influenza seasons, and we'll have overall the same area under the curve, meaning the same number of people are susceptible to severe illness and death, and the numbers really don't change. And next year, the year after, we're just back to our normal bell curve of, not bell curve, but our normal curve of influenza illnesses and influenza deaths, and it's somewhere between 30 and 50,000, and it just becomes part of our normal risk. So hopefully that happens. I'm not suggesting that will happen. I'm just saying historically, if you look at precedent historically, that's a likely outcome. So again, hopefully that's helpful. I got something on chat here. Is there something else I want to do? Okay. That is it. It's a wrap. Nice name of that.